As a subcommittee of the subcommittee, and I'll call BudgetSub3 hearing to order for today. We have today a vote-only calendar, which we won't be taking up at the top of the agenda since it's a subcommittee of the subcommittee. So we'll move directly to the items for discussion section of the agenda and begin with item 4120, Emergency Medical Services Authority. It's your lucky day. You didn't have to sit through the vote-only calendar. You can thank Senator Bonning for that when he gets here. This is one I'm missing. Get another piece of paper, this one. We'll go ahead and get started with the budget overview, and we're on page 9 of the agenda.
Okay, Senator Mitchell and Ms. Bass and Mr. Feely. I'm Dr. Howard Backer, Director of the Emergency Medical Services Authority, and this is Dan Smiley, our Chief Deputy Director. I'll provide a brief overview of our department, our budget, and integrate a response to one committee question. As far as our budget, the governor's proposed budget for 2016-17 includes expenditure authority in the amount of $36.1 million and 66.9 permanent positions. And of this amount, over 40%, or $15.2 million, is delegated for state operations, and the majority, 58%, is delegated to local assistance. The department does not have any new workload or policy adjustments under consideration by the legislature this year. Our EMS system in California was created in 1981 by Health and Safety Code Division 2.5 with the intent of creating a statewide system with the EMS authority responsible for the coordination and integration of all state activities concerning emergency medical services and to ensure the provision of effective and efficient emergency medical care. We are a small department, but with significant responsibilities that fall into 3 categories. First, pre-hospital emergency services, which is one piece of an emergency care network integrated with hospital emergency departments and other services that together provide one of our major healthcare safety nets. Pre-hospital 911 services in particular are widely seen by the public as a guaranteed medical service regardless of insurance status that's coordinated by local government with state oversight. In California, there are now about 60,000 certified EMTs and 21,000 licensed paramedics that respond to about 4 million 911 calls for emergency service annually, using 3,600 ground ambulances and 50 air ambulances. And they take the ill or injured to one of 306 acute care hospital emergency departments that may be designated as a specialty center. Specifically, our authority is responsible for scope of practice, training standards and regulations for EMT and paramedic practice, as well as first aid provided by public safety personnel. This was recently expanded to include tactical first aid. We license paramedics and discipline those licensed when necessary, and we also oversee public first aid standards, training, and regulations. These public interventions are all areas of considerable legislative activity in the past few years, and they include specific medical interventions such as automated external defibrillators, epinephrine for allergic reactions, and naloxone for narcotic overdose, and cardiopulmonary resuscitation. And finally, we set standards and certify training for licensed child care providers. One important initiative from the EMS Authority regarding the role of paramedics is an approved health workforce pilot project through the Office of Statewide Health Planning and Development to test and evaluate the use of paramedics in expanded mobile healthcare roles that fill some of the gaps in local healthcare systems and improve access to care and integration to care. Some of the projects being tested include the use of paramedics for post-discharge follow-up to prevent hospital readmissions, managing patients who frequently access 911 and emergency departments by linking them with social and other health services, taking low acuity patients to alternate destinations other than an emergency department, and working with hospice nurses to prevent unwanted emergency department visits at the end of life. Second, as with many other state programs, the EMS system is a two-tiered responsibility between state and local agencies, and we develop guidelines and approved plans for emergency medical systems implemented by our local EMS agencies. There are 33 of these agencies, 26 single-county and 7 multi-county agencies that primarily serve rural areas. And the direct 911 ambulance service is provided by a mix of public fire agencies and private providers. In this oversight role, EMS Authority also provides operational and quality parameters for the local EMS agencies, and we develop regulations for design and quality of the specialty care systems that include the trauma system, pediatric emergency care centers, stroke centers, and cardiac centers. One of our priority initiatives is to assess effectiveness of the EMS systems by using improved local and regional data. AB 1129, chaptered last year, requires EMS providers and agencies to document patient care in electronic records that can be aggregated and analyzed and used for system evaluation and to improve patient care through performance improvement. We're also working to exchange clinical data with hospitals so paramedics can have patient information in the field. And this initiative will improve care during a disaster by making critical patient information available when patients are treated in different systems. SB 19, chaptered last year, will utilize these healthcare information advances to design and test a registry for POST forms, which is the physician's orders for life-sustaining treatment. And our third major area of responsibility is the medical response to disaster. The Health and Safety Code states that in cooperation with Office of Emergency Services, the authority shall respond to any medical disaster by mobilizing and coordinating emergency medical services and mutual aid resources to mitigate health problems. So we partner with Department of Public Health to build a public health and medical response infrastructure across federal, state, and local partners, and plan for the medical impact of any type of disaster or health emergency, from earthquakes to bus and air crashes to influenza pandemics. At the core of our preparedness is a staff trained in emergency management and our state response plans that are tested and trained through exercises and events. The EMS Authority has developed a tiered response to disasters to provide medical response in the field. In the first tier are our 42 ambulance strike teams that are housed in local jurisdictions and can respond for treatment and staging of multi-casualty incidents, usually within 1 to 2 hours. And these are routinely used by our local jurisdictions for multi-casualty events or for hospital evacuations. One of the emergency coordinator positions funded in the budget last year is supporting this program by auditing these units placed at the local providers. We've already completed 32 audits of 42 deployed ambulance units. The second tier consists of the California Medical Assistance Teams, and with the new funding from last year, the Southern California Medical Assistance Team, or CalMAT program, has been reestablished. The CalMATs can deploy within 12 hours and begin treating patients in any location. These are one of the most flexible direct patient care assets because they can be deployed as a team of any size and can take on healthcare missions from acute emergency care to management of evacuated long-term care patients. In addition, we have teams that are supported by specific healthcare systems, and personnel can be pulled from our disaster healthcare volunteer registry that currently has over 21,000 licensed personnel of all types, including our locally organized Medical Reserve Corps. Both new emergency coordinator positions funded last year are supporting the California CalMAT program by developing policies, procedures, minimum standards for training and exercises, and maintaining equipment caches for the CalMAT teams. The new positions also support planning and response for all types of emergencies, coordinating closely with our Department of Public Health for catastrophic planning, for policies and procedures, and development of our state emergency plan, public health and medical emergency function. And finally, the third tier is our mobile field hospital program, but currently all 3 hospitals are stored without equipment maintenance and would require several weeks to deploy. I'll end my brief there and available for any questions you may have.
Senator Monning.
Thank you, Madam Chair. Thank you. I did want to just ask about the stored emergency field units that were the subject of conversation over the last few years. It sounds like they have been mothballed, but they could be brought out in the event of a serious emergency?
Absolutely. They are ready for the deployment, but not with the capability of being an acute care hospital on immediate deployment. It's the biomedical equipment that requires the ongoing, the most intensive ongoing maintenance. So we could certainly deploy the structures and the durable medical equipment, and then it could be used for a variety of purposes, from low acuity care. If we were going to use it for high acuity care, we'd have to do resource requests to upgrade or obtain the necessary medical equipment. Or they can certainly be used for shelters, for medical shelters or any other comparable use.
Triaging or something to move people. Where are they stored?
They're currently stored here in Sacramento.
So all three
Yes.
units are in Sacramento. And what would be, without the biomedical updating, how quickly could one of those be deployed to Southern California, for example?
We could get the get it out of the warehouse and transport it to Southern California. That should be able to occur within days. The setup requires, at least 1 to 2 days. Depending on the intended use, I would hope that it could be within days to a week.
Thank you.
Get it out the door.
Would there be any way to expedite the biomedical upgrades to be faster than 2 weeks? Could you have things that you'd have to order and hit a send button if?
Well, we could certainly have a bundled mission order request that would be routed then through the Office of Emergency Services. The prior contracts had allowed us to keep the equipment in ready to deploy mode.
So just to be clear, is that currently the situation where you could push those orders out quickly, or is there something you could do to have them more on the ready without making the financial commitment?
No, we know what we would need depending on the specific mission and the level of care that we wanted to provide. It may, though, take some time, since there's not a prearranged memorandum of understanding or vendors. It may take some time to fulfill the order requests, but it's not. There's no unusual equipment, so I would hope that we could fill the requests relatively soon. But unfortunately, the whole deployment at this point as an acute care hospital has not been tested in terms of how long it would take.
Right.
It would depend on where it was going.
Right. And I know it was a budget challenge, and I know that you all looked at various options, and at least I'm reassured to know that there's still some capacity there, if not an immediately available one. But I would just encourage that any contingency that doesn't require new MOUs or new budget allocations that could get those needs moved quickly so that we could act quickly would just be something to consider.
Yes, sir.
Thank you. Thank you, Madam Chair.
The record would certainly reflect, in this area, we have tried, Senator Monty.
That's right.
Year after year, haven't we? Thank you very much. Finance or LAO, any comment on the presentation? Nothing? Anything you want to add?
Dan?
Nope.
Okay. Any public comment on the Emergency Medical Services Authority budget overview? Seeing none, thank you, gentlemen. Appreciate it. And this was an information item only. Why don't we go back, Senator Monty, and deal with our vote only agenda? Senator Monty, if it is okay with you, since we're dealing with two departments, I thought I would do this in two motions, if you're comfortable with all of the recommendations that the agenda includes. And so I will entertain a motion to approve item 4260, Department of Healthcare Services, issues number 1 through 12.
So move, and I vote on those 12 issues.
Thank you. We still have to call the roll. That's our new policy.
Monning,
Aye.
Mitchell,
Aye. Thank you very much. Appreciate it. And I will entertain a motion for item 4265, Department of Public Health, issues 1 through 10, as reflected in the agenda.
I so move, and I vote on issues 1 through 10 as indicated.
Thank you, sir.
Monning,
Aye.
Mitchell,
Aye. Thank you. We've dealt with the vote-only calendar. We will now return to items for discussion. Item 4140, Office of Statewide Health Planning and Development. We'll hear the issue 1, budget overview. We are again on page 10 of the agenda. Mr. David, welcome.
Morning, Chair Mitchell, Senator Monning. I'm Robert David. I'm the Director of the Office of Statewide Health Planning and Development, and I've been asked to give an overview of the department and our budget. Office of Statewide Health Planning and Development, also known as OSHPD or OSHPOD, advances Californians' access to safe, quality healthcare environments by focusing in 3 primary areas: healthcare workforce development, healthcare data collection and reporting, and healthcare construction and financing. In our healthcare workforce development area, we have 2 areas of the department focusing in this area: our Healthcare Workforce Development Division and the Health Professions Education Foundation. Our healthcare workforce development programs seek to increase access to healthcare for underserved communities and populations by incentivizing a diverse and culturally and linguistically competent healthcare workforce. We focus on recruiting and retaining various health professionals in areas of unmet need. We increase the geographic distribution of California's healthcare workforce, and we explore new service delivery models. Since 2011, OSHPD has provided more than 6,500 awards, totaling more than $189 million, to support the education of health professionals in a variety of practices. One of our primary healthcare workforce development programs is the Song Brown program. Song Brown provides grants to educational institutions to incentivize increased access to healthcare providers in underserved areas through recruitment of underrepresented minorities, clinical training in areas of unmet need, and graduate placement in similar areas of unmet need. Next, our healthcare data collection and reporting area. Our division serves as a healthcare data collection and reporting hub. We collect healthcare data from nearly 6,000 healthcare facilities that are licensed by the Department of Public Health. This data includes hospital patient records as well as public aggregate utilization and financial data. We make much of this data available to the public, researchers, policymakers, the media, and others. We also produce measures, analyses, and reports on healthcare quality and outcomes and other related health topics. Since 2011, OSHPD has released more than 500 reports about California healthcare quality, cost, utilization, and outcomes on topics that included hospital inpatient mortality, access to community-based primary care, and first-time reports about ischemic stroke outcomes and hospital readmissions. We also coordinate and administer the California Health and Human Services Open Data Portal. More than 160 data sets have been published in open format from all 12 CHHS departments since the Open Data Initiative was launched in the fall of 2014. Moving on to healthcare construction and finance, OSHPD is the building department for California's hospitals and skilled nursing facilities. Our Facilities Development Division is our largest division and our most visible program. OSHPD administers the Hospital Seismic Safety Program, focused on strengthening California's hospital buildings so they can remain operational in the event of an earthquake or other disaster. In 2011, 40% of hospitals, California's hospital building inventory, which represented over 1,000 buildings, was classified as being potentially at risk of collapse in a major earthquake. Today, I'm pleased to report that more than 91% of acute care hospital buildings in the state now comply with the Seismic Safety Act. Based on information and schedules provided by the hospitals to OSHPD, the remaining buildings appear to be on track to meet the January 1st, 2020 deadline to withstand a major earthquake or be removed from service. We continue to work with the remaining facilities so they remain on track. OSHPD has also promulgated a new seismic performance category called SPC-4D that will allow older hospital buildings to upgrade to a standard that will keep them seismically compliant past 2030. This is a great option, particularly for hospitals in areas of low seismicity that would otherwise have to be replaced or removed from service. Additionally, since 2011, OSHPD has reduced hospital construction plan review time on remodel and renovation projects by more than 40%. We've increased face-to-face over-the-counter services, created rapid review services for smaller projects, and we've leveraged technology to provide real-time plan review and a one-stop electronic services portal. These innovations have greatly improved our customers' experience with OSHPD, contributed to lower costs, and improved health and safety for facility patients, staff, and visitors. And finally, Senators, our Cal Mortgage program provides health facility construction loan insurance. For California's nonprofit and public health facilities, they can gain access to low-cost financing for their capital construction needs through this program. And since 2011, Cal Mortgage has insured 43 loans totaling over $1.2 billion for these nonprofit and public health facilities. A recent example, just last month, I was pleased to attend the ribbon cutting and grand opening of the new patient tower at Chinese Hospital in San Francisco. Cal Mortgage assisted in financing $65 million for that project. Also, St. John's Well Child and Family Center in Los Angeles is another recent example of Cal Mortgage financing. Briefly, our budget overview. OSHPD's 2016-17 proposed budget is $160.8 million and 483.6 positions. We're funded primarily by special funds. Many of them are fee-supported. We have a very small amount of federal funding, $1.4 million in 16-17, that go towards our workforce programs, and we currently have no general fund expenditures. That concludes my overview. If you have any questions.
Senator Monning.
Thank you. A comment and a question. First, on the hospital seismic safety, I just applaud the progress that you're reporting. I know we've struggled with extensions versus what happens if you put a current facility out of service in the immediate seismic impact, so to speak, on a community. So it seems like the progress is being made, and some of the expediting of permitting is also encouraging. A quick question on the Song Brown scholarships. And today may not be the day we're looking at specific budget lines on that, but it's such an important program, particularly in rural areas that I represent. And I know we had some support from the California Endowment to enhance some of that. Can you just give us a brief preview of how we're doing, and is the funding going to remain stable?
Well, that's clearly the Song Brown has fulfilled an important need, particularly when you have so many Californians that have a health insurance card for the first time. There's a lot of stress on the primary care system. I think Song Brown is a help in alleviating some of that stress. We were very happy to get a 3-year grant from the California Endowment. We knew going in that it was probably a one-time grant, and we're getting that money out into the community as quickly as we can. I think it's making a difference, and I'm happy that they were able to expend those funds on a worthwhile program.
Now, those were matched with some state funds, if I'm not mistaken.
There were some. They weren't matched, but there was some additional state funding, one-time funding, that helped to augment some of our programs as well.
And again, I don't know that it's today's agenda where we're looking at those dollar amounts, but I am curious if the California Endowment grant is indeed ending or has ended, any prospect of either renewal from them or other foundations that might also join California in investing in that?
Separate from our Strong Brown program, we do have the Health Professions Education Foundation, which is able to go out and look for grant funding. You know, the Cal Endowment Grant was a big one. That'll be tough to replace, but we're always looking for additional funding opportunities from the private sector.
Great. Well, thank you. Thank you, Madam Chair. And we'll continue to be interested in that. It's an important program. Thank you.
Thank you, Senator.
Thank you. LAO or Finance, any questions or comments? Any public comment on OSHPD, the budget overview? Thank you very much. Seeing none, we'll move on. Thank you. Appreciate it. Move on to item 4260, the Department of Healthcare Services. We'll be hearing 16 issue areas, starting with the California Children's Services Program. Good morning, Director.
Good morning.
You're rolling solo on the first issue?
I'm rolling solo.
All right, let's get started. California Children's Services Program, it's page 11 of the agenda.
Sure. Good morning, Jennifer Kent with the Department of Healthcare Services. So the first item asks for just a broad overview of our ongoing work in terms of the CCS program and the kind of the linkage between what we had proposed as part of the governor's budget in January on the trailer bill, as well as the broader changes that we are working with the advocates in the counties on in making changes to the CCS program. It is the oldest program in our department. It was started back in 1927. It serves a little over 180,000 children today. Like all things that have existed since 1927, it is old and complicated, and it has grown up from a very basic program when it was called the Crippled Children's Services to what it is now called, which is California Children's Services. It services children with extraordinary medical conditions that are itemized in our regulations, but include such things as rare genetic conditions, hemophilia, cancer, cystic fibrosis, spina bifida, certain types of traumatic injuries such as serious compound fractures and other kinds of things. And I think what we are struck by is both the system of care that has obviously been in development since the start of the program, but it's also a financing mechanism and a true safety net for the children's hospitals and other specialty providers in the state of California that otherwise would not exist if it were not for the program. And we're also acutely aware of the fact that CCS not only serves the CCS children, but also the broader state population of pediatric need, as well as children in other states that may come to our facilities or our specialty care centers. So with that in mind, I think we have approached the CCS redesign in a couple of different ways. The first is the whole child model, which was proposed last summer by the administration. And what we have really been working on is looking at places in California where we believe that there are county organized health systems or other plans that are more or better positioned to look at what we would say the whole child. CCS is a condition-specific program, so it only takes care of that child's medical condition. So to the extent that the child has multiple conditions and is either in the DDS environment, has other medical conditions, has obviously school-based needs, or if there's behavioral health issues, those are not taken care of or addressed by CCS. And so what we've been struck by is the lack of coordination between all of these various programs. And so we are really looking to put these children into a place in which all of their care is both authorized as well as coordinated by a single entity. And so our proposal would have the 4 county organized health systems, so CenCal, which is Santa Barbara and San Luis Obispo, Central California Alliance for Health, which is obviously in Senator Monning's area of Monterey, and Santa Cruz and Merced County, and then Partnership, which is 14 counties in rural Northern California. San Mateo is already doing a similar pilot through our waiver today. These children would be enrolled into the county organized health system, and the plan would be responsible for coordinating their care, not only for their CCS condition, but for obviously the behavioral health and other kinds of needs that these children may have. When we put forth the governor's budget in January, part of the complexity of the program is not only with the care that these children receive through the provider network, but it also pertains to the county-state relationship as it pertains to administration of the program, eligibility of the program, and then depending on the population, we have sharing ratios and formulas with those counties. And so there's really there's three main eligibility categories of CCS children. So you have the CCS children that are enrolled in Medi-Cal plans, either Medi-Cal or they're formerly known as the Healthy Families Program, which has a different sharing ratio with the counties. There are state-only, which in state parlance, state only means children without satisfactory documentation status, but in county parlance, it is children with other health coverage are also included in that. So those are kind of your three main categories of children. So children who have health coverage through their parents, but because of their eligibility, because of their medical condition, and because it takes over a certain amount of their gross income, they're enrolled in the program. So there are both independent and dependent counties. So independent counties do the medical, the financial, and the authorization of services for the CCS program. Then there are dependent counties in which the state does those functions. There are also quasi-dependent counties in which some of the services could be done by them, meaning the financial eligibility, but we do the service authorization. So when you start to talk about putting these children into a county organized health system, the complexity of how we also work with the counties on the financing and the back end invoicing, because it's a realigned program, or at least it was a realigned program back in '91. That was really the impetus for putting that trailer bill proposal in, was we see that as a fiscal component or as a budget component because it's a state-county financing relationship. We, understand the committee's recommendation on this particular proposal, but what we also wanted to note was that the policy changes that we are seeking in terms of the beneficiary protections, the network, the requirements on the department as it pertains to network adequacy things. We proposed language back in August. We have been in ongoing discussions with the stakeholders on what that policy kind of development and proposal looks like, and I know that there's some legislation and some language that has been both recently shared with us, and I believe it may even be in print today in terms of kind of a starting proposal as to how we would go about doing this. So with that, I'm happy to take questions, but I would like to just say that, it's a very important program to both the department as well as the stakeholders. We certainly appreciate the concern by both the provider community as well as the families and the parents of these children. And so we are approaching this process with no budget implications from the terms of we're not looking for savings. This is not a savings proposal. This is more of we're trying to both improve the care coordination for children who otherwise may not have it, as well as, all of our programs within the state have really been transforming since the Affordable Care Act in terms of accountability, oversight, better kinds of data metrics and things like that. And we think that this is one of those steps in that direction. So thank you very much.
Any comments or questions, Senator Monty? While I certainly applaud your focused efforts on improving coordination of care, the strategy and process of including it in the budget does, I remain unclear about that. The language that you mentioned that's going to be in print today, you referenced it as policy language. That's TBL language or policy as in policy bill language? Policy bill language.
Okay. So I believe, I don't have my numbers right off the top of it, maybe SB 586.
Right, that's the, 587, okay.